Good afternoon, everyone. This is our publication, a comparative analysis of unilateral versus bilateral instrumentation in transforaminal lumbar interbody fusion for lumbar degenerative disorders. This is a single center large series. I am the presenting author, Dr. Vighneshwara. So we don't have any conflict of interest disclosures. So no funds were received in support of this work, and there is no potential conflict of interest affecting the manuscript. To introduce, lumbar canal stenosis is conventionally treated with surgical management, either with the decompression with or without fusion. So transforaminal lumbar interbody fusion is well known throughout the world and is performed with bilateral pedicle screw fixation and an interbody, which gives an indirect decompression even on the opposite side, and that is the principle how it acts on. Unilateral TLIF reduces the operative exposure and the cost of surgery, where you expose only on a single side. So we have had a few publications regarding unilateral TLIF in 2014 and 2013 in the recent years. We had gone through that and did our study. So ours is a single institute, single surgeon retrospective study from June 2014 to June 2017 with the minimum follow-up of 2 years. We included, we have to carefully select patients for unilateral TLIF as the failure rates can go up if we select some unинdicated cases. So our inclusion criteria included a single leg radiculopathy or a grade 1 degenerative spondylolisthesis and a recurrent disc problem. Whereas we excluded these patients from the study, which are patients with bilateral radiculopathy, grade 2 and above, degenerative spondylolisthesis, any lytic spondylolisthesis, severe osteoporosis, like with the DEXA scan of -1.5 and below, and morbid obesity. So patients were followed up for 3 months, 6 months, 12 months, and 24 months with the radiological investigation, X-ray, visual analog scale, and osseous-free disability index was analyzed both pre and post-operatively along with neurological assessment. Fusion and implant failure were determined on the follow-up by X-ray, and if there was a doubtful fusion in the X-ray at 18 months, CT scan was usually done. We also analyzed the operative time, average blood loss, average hospital stay. So the technique of unilateral TLIF, it is same as the bilateral TLIF, where you position in a Jackson frame and expose the midline, and after that only expose the paraspinal muscles are erased only on the side where there is maximum radiculopathy. If there is a left radiculopathy, then only the left side of the paraspinal muscles were excised, and then facetectomy was done. Pedicle screws were placed above and below. A laminotomy was done, and the bone from the laminotomy site was used as an autograft to fill the cage and to help in interbody fusion. And compression was achieved once the cage was placed, and confirmation of the implant position was obtained by CM imaging. Wound was closed in layers. Results. We had 112 patients in unilateral pedicle screw fixation TLIF and 121 patients in the same period with bilateral pedicle screw fixation TLIF. The mean age of the patient in unilateral TLIF group was 53.6 years with an age range of 26 to 70 years, and there were 48 females and 64 males in the study. The average operative time in unilateral pedicle screw fixation TLIF was 75.1 minutes, whereas in bilateral pedicle screw fixation was 93.38, which was statistically significant. The average hospital stay was 1.7 days, and BPS bilateral pedicle screw fixation was 2.8 days. Average blood loss during the surgery was 76.9 ml, which was almost double in bilateral pedicle screw fixation. We have all the tables. I just want you to go through the tables. So here, these are the indications for the surgery: lumbar spinal canal stenosis, degenerative spondylolisthesis, only grade 1, symptomatic degenerated disc disease, and recurrent disc prolapse. We have the VAS score for both UPSF, that is unilateral pedicle screw group, as well as bilateral pedicle screw group, where the improvement at the end of 2 years were similar and statistically insignificant. But which was really statistically significant was the average blood loss, which was almost double in bilateral pedicle screw TLIF compared to the unilateral pedicle screw TLIF, and duration of surgery was also statistically significant. So the duration of surgery was also lesser And so now we can also tell that the number of implants in unilateral pedicle screw TLIF is lesser, the duration of surgery is lesser. So definitely the cost for the patient would also be lesser. Coming to the complications, there were a few regular complications like superficial infection, pseudoarthrosis, cage migration. One patient had foot drop and implant failure, but in comparison with our own bilateral TLIF group, all were statistically insignificant. To discuss, we had a significantly reduced intraoperative blood loss compared to the bilateral TLIF group, which was statistically significant, and operating time was 7.5 minutes compared to the bilateral TLIF, which was 93 minutes. Reduced hospital stay 1.7 days compared to bilateral pedicle screw fixation of 2.8 days. And VAS and ODI scores at the final follow-up were similar. So the patient had relief, what was supposed to happen with the bilateral pedicle screw fixation. In comparison to other published studies, which had very less, like very significantly lesser number in the study group compared to ours, our study fares very well in intraoperative blood loss as well as operative time. Average hospital stay also is like minimal in our study. And to conclude, the unilateral TLIF group in selected group of patients, in carefully selected patients, would give adequate decompression and fusion. It also provides a cost-effective option with minimal blood loss and reduced operative time and lesser hospital stay. But further studies and long-term follow-up is definitely needed to identify the comprehensive criteria for the selection for unilateral TLIF patients. So this is one of our patient, just an illustrative figure, who had a complete fusion in AP lateral view as well as a CT scan and is doing very well. This is our publication, which was published this year in September. Thank you.